So that was awfully straightforward. The next, actually, no, I think this maybe was the talk I meant to give, actually. So I take it back. I had a moment of panic. We're now moving to something a little bit more controversial here, and one where really, I hope I can improve your practice. And this is sex hormone replacement in young hypogonadal women. Firstly, what the guidelines tell us, and are they telling us the truth? So just summaries, are the published guidelines on HRT in hypogonadal women in the reproductive age group? Are these guidelines evidence-based? More importantly, do they make any logical or physiological sense? I'm also going to talk about what HRT products are available and how they differ, and whether there are transferable lessons in terms of hormone replacement therapy from the trans population. And I'll try and give you a rationale as well for titrated estradiol replacement rather than blind treatment, and also in relation to kind of uterine maturation that you get in young hypogonadal women with pubertal induction. So what's the purpose of sex hormone replacement in a young hypogonadal woman? Well, first thing from our perspective is to achieve and maintain adequate bone density and reduce fracture risk back to baseline for later life. More important than perhaps, it's to permit normal sexual functioning. My throwaway gag is that you hear some women talking about sex being uncomfortable, a little bit painful. Okay, I promise you that if sex were remotely uncomfortable for me, I would stop doing it tomorrow or yesterday. It just wouldn't happen. So I think we need to be significantly more sympathetic to have female partners on this earth who I think probably are tougher than we are. Also to eliminate vasomotor symptoms, reduce long-term cardiovascular risk to baseline, and for the younger women to achieve breast development according to genetic potential, and most lately, for the young women to achieve uterine development according to genetic potential. So let's go through these guidelines. So this is hormone replacement in hypopituitarism in adults. And this is from the Endocrine Society Clinical Practice Guideline, first author Nikki Karavitaki, I believe. And this is what they say. Hypopituitary women on oral estrogen will require high doses of recombinant growth hormone. Yeah, but who cares? The reality is that you will require far more growth hormone if you use a synthetic estrogen, such as in the combined pill. Actually, I quite recommend the combined pill and acromegalix. You will need slightly much growth hormone if you use Premarin, horse estrogen. Your growth hormone resistance is a whole lot less, actually, if you use physiological 17-beta estradiol. And if you give it transdermally, again, that further induces growth hormone resistance. So this is a kind of the statement's not inaccurate, but it really crucially lacks granularity and detail. The combined oral contraceptive may be more acceptable than HRT for younger females. However, studies comparing these two regimens are lacking. So this is one of these factoids that you hear bandied around, that younger women may find the combined oral contraceptive pill more acceptable than HRT. And I think it's got perpetuated from one guideline or opinion to another. But actually, my understanding is that it has no basis in fact. No one has ever surveyed young women to ask them. And actually, when I've spoken to colleagues across the world and asked them, has any woman said to you, I would rather have a contraceptive pill because all my friends are on it? They said, no. Never heard it. And have you ever heard it for any of your colleagues? No. So this is just like a factoid. So this just needs to be struck out from, it shouldn't be a part of your equation. Studies where these two regimens are lacking, well, actually, they're not lacking. You could ask why you should wish to do such a study. I mean, why would you wish to compare, I don't know, armour-thyroid against thyroxine? Oh, I guess some people have done it, haven't they? Why would you wish to do a study in men comparing testosterone to nandrolone? But so first of all, the question is why you should wish to do a study, but actually they have been done. And actually conventional HRT comes out better. So what other bit of nonsense comes up in these clinical practice guidelines? Estrogens are available in many forms: oral, transdermal, intradermal creams, tablets, and rings, according to patient preference. So intravaginal creams, tablets, and rings, that's not hormone replacement. That's to make sex more comfortable. Measuring serum estradiol levels is not beneficial. Well, actually, who said that? That's just an invented factoid with no basis to it. Moreover, many estrogens are not detected by the assays. Well, if you're using ethanol estradiol, which is in the combined pill, then that won't be detected in the same way that you wouldn't detect nandrolone in an assay for testosterone. However, you will, if you're using physiological 17-beta estradiol, that will be picked up. And actually, even horse estrogen is picked up in immunoassays, although not in a tandem mass spec assay. So far, in these guidelines, we've got stuff that is either irrelevant, untrue, or frankly nonsense. Let's see if NICE does any better. So the 2017 quality statement. So this is the guidance on menopause, and in a brief quality statement, 3, managing premature ovarian insufficiency. And they say, women with premature ovarian insufficiency are offered hormone replacement, HRT, or a combined hormonal contraceptive. And that's it. So that one sentence, that's it. No further information. Okay, well, let's look at another guideline. The European Consensus Statement on Congenital Hypogonadotrophic Hypogonadism, on which I was a co-author, but I have to say I clearly hadn't looked at the final text closely enough. So in some ways it's good. We've said you give estradiol. Estradiol is what you give, and either orally or transdermally, with a cyclical progesterone. Look at the doses, though. They're not adequate for a younger woman. At least it's the right product, the right delivery system. The doses are too low for most younger women. And we'll talk about that later. So what estrogens are out there? So this is 17-beta estradiol, which is your dominant circulating estrogen in premenopause. Conjugating exocrine estrogen, or Premarin, pregnant mare's urine. There it is, and that's where it comes from. Actually, no, in fact, they don't have convy bags. The poor horses are permanently catheterized in stables in Canada. But I guess better there than on a restaurant table in France. Problems with that, there's an increased risk of venous thromboembolism in postmenopausal women, and also massively increased risk in trans women. So in Europe, it's been a no-no to give Premarin to any trans woman for the last decade or so. What about ethanol estradiol, which is present in almost all contraceptive pills, the exception being Clara, QLARA, which is the only one based on regular estradiol, and that's but more expensive. So there's an increased risk of venous thromboembolism in eugonadal women on the pill, and a major increase in trans women. Again, it's an app for the last 20 years. No, you never use ethanol estradiol in trans women, so natal men, because of the risk of thrombosis. There's also an increased risk of cardiovascular death in trans women. They also increase blood pressure by activating renin, which is why the pill tends to increase blood pressure, whereas HRT doesn't. And also, ethanol estradiol is a very powerful inhibitor of growth hormone-mediated IGF-1 secretion, which is why I think the pill is great for acromegalic women, but not for any others. And particularly, God only knows whether you want to give this to children. if you're concerned about their growth. You can't measure serum levels to titrate the dose as well, so what you're giving is a blind dose. And remember that ethinyl estradiol is a selective estrogen receptor modulator, so it's in the class along with tamoxifen, clomiphene, raloxifene, except it's designed to do things differently. So, for instance, clomiphene is designed particularly to de-repress to encourage LH and FSH secretion. Ethinyl estradiol is designed particularly to suppress LH and FSH secretion. So how does a pill compare to hormone replacement? So this is your conventional combined oral contraceptive, 21 days of ethinyl estradiol with a progesterone, 7-day gap, and then repeat. So obviously, if you're, and you get that bleed towards the end of that 7-day gap, and of course, if you're a hypogonadal woman during that gap, you've got no estrogen on board whatsoever. So 1 week in 4, you've got no bone protection, and maybe hot flushes, sexual dysfunction. You can take the pill back to back, but people often get a bit bloated that way. And then hormone replacement. This is conventional cyclical hormone replacement. So the estradiol, generally it's proper estradiol in there, which is given continuously. The progesterone is cyclical. So about 4 days of progesterone in the second half of the pack, and the bleed occurs just after you finish the course of progesterone, and then repeat. So that's the difference. And continuous combined HRT is where effectively it's the same dose of progesterone overall, but spread out over the full period. Or you can use the Mirena IUD, which would be my favorite. And let's have a look at what studies have been done. And again, I would stress also that these studies have been done using the fixed dose of the combined pill versus fixed dose HRT. And of course, by using a fixed dose HRT, you're losing some of the benefits, which is actually the ability to titrate the dose according to serum levels and patient response. So you're effectively, in this battle between combined pill and HRT, the HRT's kind of got one arm tied behind its back. And so, interestingly, compared to the combined pill, HRT lowered blood pressure by 7.3 millimeters of mercury. HRT improved the BMD-Z score, and also it increased markers of bone formation, and interestingly, it seemed to improve renal function. So, what's happened there? Sorry, I'm doing the wrong. And so another more recent study, Cartwright, 2016, 2-year open label RCT, a fixed as HRT. Again, I would say fixed as HRT is your not exploiting its possibilities to the utmost, versus combined pill, and also some non-randomized observation of hypogonadal women who just refused treatment. And the main outcome was looking at bone density. 59 women recruited, 36 completed the trial. So clearly both HRT and the combined pill were better than no treatment, but actually the results did favor HRT in terms of bone density improvement. So I've talked to you about the kind of guidance that's been published internationally in terms of the Endocrine Society and hypopituitarism, NICE in terms of premature ovarian failure, and the European guidance for women with hypog. And let's compare that to what the Northeast England guidance is on estrogen replacement in transgender women. And I think the granularity in this in detail is hugely helpful, and it would make sense to apply this to, well, I think that cis women deserve the same degree of care as trans women. So, ethinyl estradiol is associated with increased mortality and is no longer recommended. Ethinyl estradiol and Premarin result in a procoagulant hemostatic profile in trans women with increased thrombosis risk and are thus not recommended. The estradiol dose is prescribed according to serum estradiol levels. Yep, we're endocrinologists. How about measuring a level? Estradiol levels should be in the upper half to third of the female follicular range, which in most laboratories will be somewhere in the region of 300 to 600 picomole a litre. The doses will vary: oral 1 to 6 milligram a day, gel 1 to 2 milligram a day, patch 50 to 200 microgram daily. And you can see with the higher doses, you're not going to get a combined preparation of that dose. You may have to hack or adjust or put in add-ins to achieve those higher doses if it's necessary to achieve adequate levels. So what might be your rationale for titrated estradiol replacement, apart from the fact that it makes damn common sense? So we have a study from Yarvin and Maturitas comparing estradiol concentrations and bioavailability, single dose and at steady state during treatment with oral and transdermal estradiol. They found that oral bioavailability was simply higher than transdermal. I suspect they may have changed now with newer transdermal preparations. But crucially, they find a really wide inter-subject variability in estradiol levels with both the oral and transdermal. And this suggests quite right that individual dose adjustment may be needed. Again, the idea that we would give the same thyroxine dose to everybody without measuring a level. Another rationale for this would be looking at simply what does happen in the healthy state. So actually, if you look at the integrated estradiol concentration, your area under the curve in healthy girls in all menses, your mean estradiol concentration is 300 to 400 picomole per litre. That gives you an idea what a healthy target might be. And if you look at data from Conway, Professor Jerry Conway, UCL in Turner women, these are levels that they found on particular estradiol regimens. So on oral estradiol, 0.5 milligram a day, 6 picomole per litre, it's pretty low. 2 milligrams a day, which is actually your standard, that's the highest strength combined HT you can get. Again, suboptimal, 169. On patches, similar. On high strength patch, a bit better. And I think the key thing is that oral HRT and some transdermal forms, which are formulated to suppress menopausal hot flushes, may well achieve inadequate serum estradiol levels in hypogonadal women. So let's go back to another effect of estrogen, which is to cause uterine development in teenage girls. And so this is the degree of detail you can get from sonographic measurement, and these are the kind of dimensions that would be measured by a really good sonographer. And we know that during puberty, the uterus increases in length, width, and depth to achieve a mature adult configuration. And remember, if you're a hypogonadal woman, it doesn't mean you won't be able to carry pregnancy. So if you've got secondary hypogonadism like Kalman's, ovulation induction is very easy. And even if you've got primary gonadal failure, potentially you could have egg donation. But of course, if you've got a fully developed uterus, because your pubertal induction wasn't adequate, or your HT wasn't adequate, then that's going to limit your ability to carry a pregnancy to term. So as the uterus develops in puberty, the cervix gets proportionally shorter, the fundus gets longer, and the cross-section goes from tubular shape to heart-shaped. And there's really good data from UCL, actually. In fact, this has been published in Clinical Endocrinology since. And they looked at 56 hypogonadal women who'd had complete pubertal induction. None of them were hypogs, 19 premature ovarian insufficiency, and 28 Turners. And they compared these to nulliparous healthy women. And they found that actually the menarche that occurred in these hypogonadal women was significantly later than occurred in healthy women. There's issues of delay in diagnostic pathways, but crucially, all the uterine diameters and ureteral volume were all significantly reduced compared to those seen in healthy women. And I mean, UCL has got to be one of the crack centers worldwide for inducing puberty in hypogonadal women. So if even they are having difficulty achieving normal uterine volumes, that tells us that there are lessons that we need to learn. And here they're just so, again, so the control's having a uterine volume of around 50 cm cubed, whereas the hypogonadal women achieving uterine volume, mean volume of just over 30. That's a big difference. Big difference if you're a baby trying to grow inside there. So a lot of the focus of pubertal development in pediatric practice has been really to do with optimizing breast development. And that's why the breast exam is part of your process of inducing puberty. But actually, really, we probably need to move on and put sonography of the uterus into the paradigm of tests we do when we're trying to induce puberty in a younger girl. So one of the classic bits of teaching is that you gradually increase the dose of estradiol to achieve optimal breast development. And then once you've, but then when the girl gets their first cramping or bleeding or spotting, conventional teaching is, oh, that's the time to convert them to combined estrogen progesterone hormone replacement. Thing is, though, is that once you introduce the progesterone, you then put a limit on both breast development and uterine development. To the extent that some of you may have seen hypogonadal women who were just started straight off on estrogen progesterone hormone replacement or on the combined pill, and they get catastrophically bad breast development. So what we're really moving to now is to say, actually, we've increased your dose of estrogen, you've got some cramping or bleeding or spotting. Before we produce titrating a progesterone, are you happy with your breast development? And second, are we happy with the uterine development and ultrasound? And if the answer to these two questions is no, then what we will do actually is back off slightly on the estrogen dose, just to keep you on it longer. We will try and avoid putting in that progesterone until you're happy with your breast development and we're happy with your uterine development. And that's a bit of stuff that's really getting traction in pediatric endocrine practice. It hasn't yet made it to the textbooks yet. So we know that for both hypogonadal girls and trans women, incremental estrogen achieves the best final breast development outcomes. We know that for hypogonadal girls, inadequate attention is paid to uterine development as a marker of satisfactory pubertal maturation. We know that higher maintenance estradiol doses may be required to achieve optimal uterine maturation in hypogonadal women. So it may be a dose thing, it may also be a delay thing. So it may be that by simply initiating treatment later on and delaying things, that may also have an adverse effect on uterine development. And specifically, a couple of studies have shown that ethanol estradiol, as found in the combined pill, may achieve particularly poor uterine maturation. This is some data that our former fellow Dusun Sui was preparing from Newcastle, but we've since continued to add to it. So about 100 women with effective congenital hypogonadism, mainly Turner's, some congenital hypog, all on hormone replacement. Just to say that I don't have any of my women who are on the combined pill. None of them, they're on HRT. And of these 100 women, 65 achieved serum estradiol levels in what you could call the target range. And of those with estrogen on target, around a third required non-standard doses, higher than that found in standard HRT. So the highest dose patch is a 100 microgram patch. These women have to either stick on 100 and 200 at the same time, or 150 simultaneously to achieve adequate levels. Or if they're on a gel, more than 1 milligram a day, or if they're on oral, they were on more than 2 milligram a day. So for instance, they may have been on, say, Femiston 210 oral HRT or LSG 2 milligrams HRT. But in addition, they were given 1 milligram or 2 milligrams extra estradiol a day to try and to achieve adequate levels. And of course, so really what we're saying is that standard HRT is inadequate for nearly 60% of younger hypogonadal women. You have to kind of hack the preparation. So conclusions really on this is hypogonadal girls should receive timely pubertal induction with incremental dose of estradiol until adequate breast and uterine maturation has been achieved. Hypogonadal women should be treated with physiological HRT regimens based on estradiol and not with the molecules. We don't treat men and boys with nandrolone, nor should we treat women and girls with anabolic steroids such as ethanol estradiol found in the pill. HRT products generally don't contain enough estradiol for the metabolic, bone, and reproductive health of most hypogonadal women. And we should measure level, and we should supplement the baseline HRT product with additional estradiol when we found we're achieving inadequate serum levels. What's endocrinology? Endocrinology is we replace the missing hormone by titrating against clinical response and serum hormone levels. And really, we do that for men with testosterone, we do that for everything else, and why should women be any different? They deserve better.
So my second question, when is the best time to check the estradiol level in women who are receiving the synthetic estradiol?
You can't check it. If they're on synthetic estradiol, you can't check a level. That's why I don't use it. Don't ever use, always use the real thing.
Okay.
If you're treating a patient with ethanol estradiol or a pill, you're treating them blind. All you can do is look at their bone density every 5 years or so. And then if it's crap, what can you do? Well, you can't adjust it. It's a fixed dose.
Right. So I will ask another question then. How big is the gap between what we are supposed to do as general endocrinologists and what the reality is?
For men or for women? Or
for women?
For women, for young hypogonadal women, I think the gap is pretty enormous. So often in our older women, we find ourselves kind of playing catch up. So for younger women who really didn't get adequate treatment earlier in life, we're having to play catch up later in life by, for instance, keeping them on HRT beyond 50, up to 60, early 60s, trying to make up for what was missed before. One of the scary things is in relation to the other bone protective drugs. So we know that you can use bisphosphonates safely for up to 5 years, and then over 5 years, you've lost your safety efficacy data, and you really have to stop. And then what? So then we have denosumab. Denosumab is like the picture of Dorian Gray. So the Oscar Wilde book. So Dorian Gray is always young and beautiful all the time, and the picture up in his attic, wherever, is getting older and older, nasty, more wrinkled, and it all works fine until he's brought face to face with his portrait, and then suddenly the portrait goes back to being a handsome young man, and he ages into this like stupendously, appallingly, a little bit like that scene from Indiana Jones and the Last Crusade, and that's with denosumab. So you have your last injection of denosumab, and within 18 months of that, your bone density has gone back to being worse than if you'd ever started denosumab in the first place. You're Dorian Gray. You met your picture, and actually your fracture risk within a year of stopping denosumab absolutely shoots up. So realistically, nobody really needs. You start with the principle that really nobody can ever afford to stop denosumab, and denosumab doesn't have practical data beyond 5 years, and doesn't have theoretical data beyond 10 years. So really, denosumab, you don't really want to be starting that until you're at least in your 70s. which in turn tells you that bisphosphonates, you don't really want to be starting those until you're well into your 60s. So therefore, we need to do everything we can for women before that, because actually there is no hinterland. If we don't get the HRT right when they're younger, there isn't this miraculous succession of bone drugs that are going to keep them healthy into old age. We really have to reserve bisphosphonates until people are well into their 60s, and similarly denosumab until they're well into their 70s.
Right. Does anyone have a burning question? Otherwise, I think I can collect all questions on my email, and then I can send them to Dr. Quinton, and maybe he can get back to us within the next week or two based on how busy he is. Otherwise, I'll just leave a last word for Dr. Quinton before we close.
So many thanks for this. It's a pleasure to hear from you again. I do miss you all. I hope we'll all meet up again in person in better times. Big hug to you all.
Sure. Thank you very much, guys. Thanks, Dr. Quinton.
Thank you very much, Dr. Quinton.
Thank you so much, Dr. Quinton. Thank you.
Bye-bye.
Thank you, Dr. Quinton.